The effect of the Covid-19 outbreak on the lung cancer pathway is of real concern and has been brought into sharp focus by the report of the UK Lung Cancer Coalition entitled Covid-19 Matters. I shall refer to it later and the discussions I've had with Martin Grange, Professor Mick Peake, OBE, and Dr Robert Rintle from the UK Lung Cancer Coalition. When Parliament is debating health matters, we often focus on policies, funding and statistics, which of course is very, very important. And I shall address these later, but when we speak about a specific disease, the one that most people will have little knowledge about, I believe we need to explain the impact it has on patients and their loved ones. In doing this, I wish to share a real example of a lung cancer case. The patient concerned had a persistent cough for a few weeks. After prompting from their family, the patient went to see the GP. The GP prescribed some medication, and the patient was advised to come back in 2 weeks if the cough persisted. It did. The GP sent the patient for an X-ray, and the next day, the GP called the patient in to see him. It did not look good. There appeared to be a large tumour in the right lung, and it had spread. The patient was given an urgent referral to the local acute hospital. Tests were done, and it confirmed stage 4 small cell lung cancer. It had also spread to the rib, liver, and lymph glands. The consultant told the family as sensitively as he could that it was terminal, and at the best the patient would have 6 to 9 months more of life. The oncologist said he wanted the patient to try some chemotherapy, but it had its risks, and if the patient gets an infection, it could cause serious complications. Unfortunately, the patient did develop an infection, and the following day is rushed into hospital very poorly and in great pain. The hospital gets the pain management wrong. The patient is admitted, and it's another 24 hours before the pain management team see the patient to get control of the situation. A no resuscitation form is signed. However, the patient recovers from the infection and goes home, but more infection occurs in the lung. The lung collapses and the infection gets worse, filling the lung with pus, and the smell is awful. The patient must go to another hospital to have a drain inserted into their chest, but it does not always drain the pus in the way intended. So the patient needs to return to the hospital on several occasions to have the drain looked at, and on occasion, because the lung is filled up with so much fluid, needs to be drained by the brilliantly caring specialist nurse practitioners. Despite all this, in the final few weeks, the patient finds some inner strength and manages a little bit of travel to tick off a couple of things off their bucket list, and then gives a knowing nod to the family to say, I showed you that I could do it. Then there's an inevitable weight loss, the loss of appetite, the puffing up of the face from steroids. The cancer, after being reduced by one course of chemotherapy, comes back with a vengeance and quickly spreads to many parts of the body. The family feel helpless, just wanting to do everything they can to help, support and show their love. The patient is brave but is more concerned about the impact on their children than themselves. The pain management and care from the GPs and district nursing team is exceptional. And then eventually, in just 48 hours, matters take a turn for the worst. And on the final day, in a matter of hours, the patient slips into unconsciousness. The end comes just over 6 months from diagnosis. The family feel numb, and the intense grief and sadness takes over. This is the reality of lung cancer. Lung cancer is the leading cause of death in the UK. Approximately 35,000 people die every year with lung cancer, which is more than breast cancer and bowel cancer combined. Despite the high mortality associated with lung cancer, it is not the most common cancer in the country. Breast cancer is the most common cancer, but is generally diagnosed earlier by stage 2, resulting in a much higher survival rate. This is not the case for lung cancer. 49% of lung cancer patients are diagnosed at stage 4. Late diagnosis is the main reason why lung cancer is the cause of most cancer deaths in the UK. Patients present so late because symptoms do not appear until stages 3 or 4. Like other cancers, the early detection, the more likely the survival. But only 19% of lung cancer patients will survive beyond 1 year if they're diagnosed when the disease is spread. We know that people most likely to suffer with lung cancer are 55 and over. They are likely to live in an area with high pollution levels and also likely to have been a smoker at some point in their life. Symptoms often only become apparent in the latter stages because the lungs are so large, which results in small tumours, cancerous or benign, having no instant impact on the person. It's only when the tumour grows larger that it begins to affect the lungs' ability to function, and this is when and why coughing begins. Whilst something as simple as a cough is often the first symptom when a patient sees their GP, with a cough, they may be sent away with antibiotics. Because symptoms present so late, the speed of diagnosis is of the utmost importance. And I believe as we exit the pandemic, it's likely that we will see a backlog of lung cancer cases. Does the Honourable want to intervene?
Thank you very much indeed. James Daly, I'm afraid. I do. Not at all, not at all. Can I just ask the Honourable Gentleman to make a very powerful and articulate description of the appalling disease that is cancer? The petition that forms the basis of this debate here today comes from my constituent Andrew Jenkinson, who sadly his wife Emma died of brain cancer during the pandemic, and his concern is regarding what is the ongoing issue of patients receiving cancer treatment during the difficult period that we're in. Would you join me in paying tribute to Mr Jenkinson for the tireless work he has done to bring this attention, not only to local level in my constituency in Bury North, but nationally here today?
I will, of course, pay tribute to Mr Jenkinson. Obviously, my condolence to his loss as well. And he raises a very important point about the impact of the pandemic on cancer treatment and survival, and I'll address that in more detail in the coming minutes. It is vital, therefore, that we do not take risks with people's health and ensure that a proactive approach is taken. There is widespread concern that during the Covid-19 pandemic, there has been too few face-to-face appointments. Lung cancer experts have told me that they believe that face-to-face appointments are important in referring people for urgent, fast-track checks and that they should resume as soon as possible. GPs need to see patients and patients need to know that they are receiving a full and thorough examination when they present with problems to their doctor. My constituency of Halton has one of the highest rates of lung cancer rates in the country. It is also a hotspot for other respiratory diseases such as COPD and asthma. Widnes and Runcorn are old industrial towns famous for the former ICI chemical plants. Many of the older generation are suffering from the pollution that they inhaled as children and as younger adults. It's exactly these people who were also encouraged to smoke in the 50s and 60s, in the 1950s and 1960s, that would be most likely sufferers of lung cancer. Quite simply, the situation they find themselves in through accidents at birth puts them at a higher risk of developing lung cancer. It's not widely known. Those who have never smoked can also be the subject of the disease. In fact, non-smoker lung cancer is the 8th biggest cancer killer in the country. It is responsible for around 6,000 deaths a year. I was shocked when I found this out. We have come to believe that only those who have smoked can develop lung cancer, but that simply is not the case. In an article for the Journal of the Royal Society of Medicine, Anand Bhopal, Michael Peake, David Gilligan and Paul Cosford discuss never smoke lung cancer. They note that never smoker lung cancer is increasing in absolute terms and in relative terms compared to the decline in smoking. Their research shows that while second-hand smoking is a contributing factor, it is not the main reason as to why this is happening. They also note that never smokers feel a stigma around their diagnosis. We must work on destigmatising lung cancer, particularly as the number of never smoker patients rises, and at the same time, publicity campaigns would help raise the profile of this silent killer among never smokers. There has been some good progress in the battle against second-hand smoking, as we know. I would argue that it's not only the never smoker lung cancer patients that needs to be destigmatised, but also smokers and ex-smokers, as these patients can feel blamed for having lung cancer. As I said earlier, decades ago, it was acceptable to smoke for a generation of people. There needs to be more support now and positive encouragement to quit. The ultimate message should be that it's better to be safe than sorry. We need to see GPs make more referrals for chest x-rays and increase the chance of early diagnosis. GPs should be screening their patients to target those most at risk, and government providing more resources for GPs. X-rays are relatively inexpensive and quick for the NHS to perform, and they are often available locally in the community, causing little, if any, convenience to the patient, which is the case in my constituency in Halton. The pandemic will have adversely affected the detection of lung cancer. As we know, a new continuous cough is one of the main symptoms of Covid-19, and it is not unreasonable to suggest that there could be people out there who have been suffering with and have potentially died of lung cancer during the pandemic without any diagnosis or treatment. or they have presented too late. It is vitally important that people who have had a cough for longer than 3 weeks see their GP. There was a staggering 75% drop in the number of patients urgently referred to lung cancer specialists during the first wave of the pandemic. During this time, 55% of UK lung cancer specialist nurses or team members were redeployed or unable to work as a result of Covid-19. It is estimated that in the UK Lung Cancer Coalition COVID Matters report that at least 1/3 of lung cancer patients have already died since the beginning of the pandemic. There is also the chance that some of these deaths may have been labelled as Covid-19 due to similar symptoms. The government should heed the advice of the Lung Cancer Coalition and pilot Be Clear on Lung Cancer and Covid-19 campaigns. These campaigns should increase awareness of potential lung cancer symptoms and increase the public's confidence across the UK in engaging with the healthcare system early. The Lung Cancer Coalition also want national NHS bodies to support the resumption of lung cancer screening programmes at the earliest opportunity. When will they resume? There is a report in the Health Service Journal yesterday that there is a shortage of equipment and staff. The Lung Cancer Coalition pushed to increase the 5-year survival rate from 16.2% in 2017 to 25% by 2025. They felt that this target was achievable, but they now believe that this is unattainable by 2025 because of the pandemic. It is clear that the pandemic has had and will continue to have a detrimental effect on lung cancer patients. Lung cancer patients are also at particular risk of contracting viral infections like Covid-19 because of their underlying condition and immune suppression associated with many lung cancer treatments. The Health Service Journal reported yesterday that since the start of the financial year, total two-week wait referrals for lung cancer stand at 18,400, down 42% from 32,000 in the same period last year. Paula Chadwick, the Chief Executive of the Roy Castle Lung Cancer Foundation, has told me that since the start of the pandemic, they have seen the requirement for support significantly increase. Calls to the Ask the Nurse helpline have risen by 93%, with patients and carers understandably anxious and with questions surrounding shielding, diagnosis and treatment. Recognising the effect of COVID on lung cancer, the Foundation took action, accelerating and extending their activity for Lung Cancer's Awareness Month campaign. They also launched the Still Here campaign with the aim to increase disease and symptoms awareness. And they say a cough does not just mean COVID, for example, and encourage and reassure those with symptoms to contact their GP. Going forward, we need a strategy that gets us back on target to achieve the 5-year survival rate of 25% set by the Lung Cancer Coalition. We need to see campaigns encouraging people to visit their GP if they have symptoms of lung cancer, especially if they live in high-risk areas. The battle to end lung cancer will be a long and painful journey. Every year that we fail to reach the 25% target, there will be people dying that would have had a longer life. Memories that could have been made will be taken away. Families that could have been spared some grief will have to endure the pain of losing a loved one. This needs urgent action before the progress that was made turns out to be progress in vain. In summary, I would say to the Minister that lung cancer should be a top priority as we move out of the pandemic. The shocking 75% fall in urgent referrals is deeply worrying, and we must ensure that urgent referrals are at the pre-pandemic level as soon as possible. We need to see a return of face-to-face consultations so patients can have the confidence in the treatment they are receiving and the right diagnosis. We need to ensure that places like Halton, where there's a high prevalence of lung cancer, are prioritised for a programme of targeted screening and chest x-rays. This will see targeted campaigns like those suggested by the UK Lung Cancer Coalition that encourage those at risk to see their GP, whilst also encouraging GPs to take a more cautious approach when someone in an at-risk group presents with a cough in the years and months to come.
Thank you, Ms Farage. It's a pleasure to serve under your chairmanship. I would first like to congratulate the Honourable Member for Halton on securing this debate and for sharing the patient story, showing the huge care not only delivered by the NHS workforce, but also the challenges for the patient as they struggle to find diagnosis, as they struggle to navigate the system. In the patient's story he articulated, there was already spread, and not only was it a stage 4, but it was metastatic, so they were dealing with different sites in the body. And all these things offer a challenge, and he very articulately laid out those challenges of late diagnosis and how we improve, and how arguably the Lung Cancer Coalition report articulated how we mustn't lose that progress that we've seen over the last 10, 15 years, how we must absolutely focus on that aim to extend survival up to 2025. And hopefully I can reassure him that those initial measures that we made at the beginning of the pandemic, because we did not know what we were dealing with, have very much not been the focus since June, since we began to refocus our efforts and double our efforts on trying to make sure that cancer patients can have the full access to the services. But I would say now that there are still some challenges. I've had conversations with thoracic surgeons. As he outlined, there are particular challenges with the trajectory of this disease because of where it is on the body, and some of the aerosol generating procedures that are needed in diagnosis and so on. But I can say to him frankly and honestly here that we are aware of those things, and we are working hard to try and not only get back to where we were. I think in the report it said, I think Professor Peake said, to a new normal, a normal that is better than what we had when we started it. I'd also like to pay tribute to the constituent of my honourable friend from Bury North, Andrew Jenkinson, and add my condolences for the sad loss of his wife. But to really congratulate him for the energy in campaigning, because it is very often just the biggest tribute you can give to the person that you love as you drive forward and try and make things better for others. Yes, of course.
And thank you very much, because that will mean a lot to Mr Jenkinson. I thank the Minister for those kind comments. The petition that Mr Jenkinson put that states the following: that it was to ensure access to treatment and screening for all cancer patients during Covid-19. Now, we know that there have been challenges. Clearly, the pandemic has thrown up things that we never thought we would dreamt that we'd be dealing with. But can my honourable friend offer some assurance that the issues that Mr Jenkinson highlights in his petition are being addressed and there are positive signs going forward?
Thank you, Madam Chairman. I will indeed hopefully come to it and hopefully give him and others the reassurance that we are focusing hard on making sure that not only can we deliver, but that we learn things from the pandemic, which was highlighted in the Coalition report as well, that actually where we can make improvements to speeding up the delivery of diagnosis, or we can speed up treatment, we really need to make sure that we do those things. So we know how important it is, as one of the country's most invidious cancers, that lung cancer is diagnosed as early as possible for treatment to be successful. The Honourable gentleman highlighted that it's one of the poorest cancers for being diagnosed too late, largely at stage 4, and it's often spread. And the challenge with that is obviously the treatment options are reduced because of the grade of the cancer. But when someone does present, it is vital that they are referred swiftly for further diagnostics, remembering where we are in a pandemic with the disease that attacks the respiratory system as much as anything. And this is where lung cancer is, not all cancers are the same. I've stood in this chamber talking about teenage cancers, and diagnostic and treatments already this week. Not all cancers are the same, and they all need a slightly bespoke look at them, and I think it's important that we remember that. I spoke to a thoracic surgeon at the Cancer Hub during the summer, And he explained to me in some detail the challenges, but also those opportunities that we now have before us. I would like to thank the cancer workforce for all they've done through the pandemic and their continued effort to restore services, because it has been a Herculean effort, and they have really flexed in the way that they've joined together in cancer hubs, and they've made sure that areas are COVID secure for patients, because that's the other thing. Part of this is to encourage patients to come forward for those tests, because if you've had that persistent cough, you need to do something about it, or if you have other signs of other cancers. As I stood here yesterday and this morning talking in those debates, I know only too well of the devastation of what Mr. Jenkinson must be feeling and has felt. But the particular concern with lung cancer is that overlap of Covid-19 symptoms. Now, that was highlighted in the Lung Cancer Coalition report and by a plethora of clinicians. And to that end, we have updated 111 protocols so that if somebody has received a negative COVID test, has a persistent cough, it may indicate lung cancer, and they are directed to appropriate clinical care. Because one of the challenges has been that there's been the sustained fall in those people coming forward for lung checks, the number of people seeking checks was only at 76% of pre-pandemic levels, making sure that we encourage people to come forward, driving forward campaigns such as the Cancer Alliance in Greater Manchester and the North, their campaign Do It Yourself, making sure people are aware of the signs and symptoms and that they approach is really, really important. It has a impact on the number of lung cancers diagnosed and treatment starts. And I can't stress enough, you can't find anybody wanting the individuals to come forward, because if they don't come forward, we can't get them into the pathway. And the optimal pathway has shown real improvements in how we can help people through their cancer journey. So I was pleased with the 150 million of capital funding issued to regions in October to invest in diagnostic equipment such as MRI and CT scanners, because again, that was something very much called for. The instant referral to a CT scan was, I know, is an objective of the report, but actually getting the equipment there so that we can start to deliver quicker routes is part of the issue. And the further 325 million for new diagnostic equipment in the spending review, once we know exactly how it's going to be allocated, I hope we'll see more delivery of diagnostics into cancer care. It's vital we use that money to maximise equipment in as many places as possible so that individuals can be treated as rapidly as possible. Because we know that access to diagnostic, earlier diagnosis, screening improves clinical outcomes. And that late stage is really one of the challenges, which is why I'm really pleased to see the hugely successful pilots of the targeted lung health check programme rolled out. Those were the pilots that offered places such as supermarket car parks, lorries, where people could easily access a check, which is largely what the Honourable Gentleman, particularly in areas of high prevalence or high inequalities, making it as simple as you can for somebody to get a check. That's what they did. They showed dramatic improvements in those attending and huge upturns in the number of people who were diagnosed. The pilots were paused due to Covid-19, but I am really keen that we turbocharge them. Now we've got them back on track, so they're operating more broadly as soon as safely as possible. The programme will be rolled out to 23 CCGs and is focused on areas with some of the highest rates of mortality from lung cancer. Because I'm short of time, I won't repeat what he said, but we know that we have that regional variation, and we need to actually target more effectively for lung cancer where we have those problems. It's important that we do that geographically in light of the need to minimise trips to hospital, particularly for people who may be more vulnerable to COVID-19. Radiotherapy services have made use of fewer fraction protocols as emerging evidence has emerged. The focus on recovery has been on embedding the use of hypofractionated treatment, and in addition, the NHS is supporting providers to accelerate the delivery of stereotactic ablative body radiotherapy for non-small cell lung cancer and oligometastatic indications, starting with the treatment of non-small cell lung cancer, as in some cases this is an alternative to surgery. And again, I think the report picked up on that, because the challenge is if you get Covid-19 at the same time you're having this surgery, it dramatically increases the mortality rate. And it was right to react at speed, and where clinicians say we need to be doing it this way, we have tried to give that direction so they can. Individuals can safely go to their GPs. They are open, and if they have worrying symptoms that could be cancer, GPs are open for business and are there ready to help patients. So making sure that the Help Us to Help You campaign from earlier in the year actually delivers and gets more people coming through the door so that we can help treat them quicker. Yes, of course. Are we allowed the extra minute or two? No, right, yes, do, quickly.
It's just on the issue of GPs, but it is important, though, that GPs do see these type of patients face to face.
Indeed, and they stand willing and ready to see those patients and give them the care, and actually making sure that they can refer quickly has been part of this drive. Now, the Cancer Task Force Recovery, led by Professor Peter Johnson, is also involving cancer charities, involving clinicians and other expert stakeholders, is also driving to meet some of the objectives that the Honourable Gentleman alluded to, making sure that we actually get people into treatment as quickly as possible, that systems pathways are clear and understandable for the patient, and that we do see that capacity rise.
Order.